Well, welcome everybody. This hour will go fast, so I'm going to get started. We're so delighted to have you join us today. We've gotten so much interest in this webinar, and we're really especially delighted to have Dr. Howard Kornfeld present today. I'm going to be doing a brief introduction, and then we'll be getting started with the use of buprenorphine for pain. I first wanted to give a little context. CHCF about a year ago committed to work with partners across California to lower opioid overdose deaths, and we've got many projects going in that area focused on safer prescribing, on better access to medication addiction treatment, and better access to naloxone. When you look at how to decrease overdose deaths, it's obviously a very tough lift, and there's many things feeding into our overdose epidemic, and many things we're going to have to do together to work on to change the course. And one way that I found most useful to bucket the work that needs to be done has to do with 4 strategies where we have clear evidence of what works. And the first, being quite obvious, is avoiding new starts. If we were to use opioids for fewer conditions, for fewer days at lower doses, we'd have fewer people going down the path of chronic opioid dependence or addiction. Certainly, if we had better addiction treatment, that would be number 2, especially medication-assisted treatment, methadone and buprenorphine, which have been shown to be effective and life-saving in opioid addiction. We would lower deaths. The third is spreading the use of naloxone, co-prescribing or making it available in the community. This is an antidote to reverse the effects of opioids and prevent overdose deaths. And the fourth category is much more difficult, and this is where we've had providers across the state reach out to us and say they need help. These are people who have been on opioids at high doses for a long time, who often are not doing well. They are often have worse pain, or certainly no improved pain than when they started, worsening function, weight gain, testosterone impact on sexual dysfunction, on mood. And one doctor labeled these the chronic miserables. What are we as a community to do with the people who have, in good faith, started opioids for chronic pain conditions but are not doing well? And we've certainly seen a lot of reactive approaches where people have been abruptly tapered off these medicines and not done well, or even kicked out of a practice, or not been able to find new doctors. There's a new category of what we're calling opioid refugees, the people who have become dependent on these medicines with no medical home. And certainly we've seen some emerging data that lowering people's doses when they've become tolerant to high doses, they tend to do better. Some people are able to slowly taper off these medicines altogether. But this webinar is focused on a new category of intervention, which is transitioning people to buprenorphine. And this webinar today is going to focus on why we would do that. What's the rationale for transitioning people who've used opioids for long-term without addiction to buprenorphine? And we certainly are excited to have our expert, Howard Kornfeld, to take us through that. Many of you know Dr. Kornfeld. He's a nationally known researcher and has done cutting-edge work on rethinking how to use buprenorphine and helping us understand how it can be used in the inpatient setting and how it can be used for pain. And most recently, he's become internationally known as the person for whom Prince's team reached out to get help the day before Prince died. Obviously, Dr. Kornfeld cannot talk about this. This is due to patient confidentiality, but for those of you who are interested in knowing the story, his son, Andrew, wrote a beautiful piece on the CNN website about his experience arriving at the estate and finding Prince already died from a fentanyl overdose hours before. So his piece is beautiful. It's on CNN, and we can make that link available to all of you. And it's an appeal for better access to addiction treatment. So now I'm going to finish up our intro. If you can advance the slide. Robert, I want to tell you a little bit about what's coming up. For this meeting, since we expect to have 100 people, we will have all the lines muted, but we have the chat box available, and I will be monitoring that chat box and seeing up questions. So please feel free to ask questions it's called the question box, not the chat box, and it should be on your right. Ask questions freely, and if there's ones that we don't get to, we'll find a way to make sure they're answered afterwards. We will record this session, and we will send out to you a link within a week with the slides and the recording. And again, we will ask you to take a survey at the end so we can know what we can improve upon. Next slide. We have a lot going on at CHCF, and we have several events coming up, and you can always go to our website to learn more. We're going to be having a webinar at the end of June about Cures 2.0, where the Director of Cures, an emergency physician, and a primary care provider will talk about practical advice about how to use it in the practice setting. And then we're very excited to have Dr. Corey Waller, who's been a speaker at several CHCF events. We'll be talking about Addiction 101. It's a fascinating talk where you'll learn about what neurobiology teaches us about how chronic opioid use changes the brain. And Corey's a very engaging speaker and brings neurobiology to life in a way that I've never seen before. We also, as you probably know, support opioid safety coalitions across the state, and we'll be having coalition convenings in the fall. And those of you who are not affiliated with a coalition will still have the opportunity to attend, and emails will go out within the next month or two. So now I want to see, do we have Dr. Cindy Grand on the line? Well, we invited a rural physician from Washington to join us to tell a story about her own experience with buprenorphine, and we'll have her join at the end. And I'm going to turn it over now to Dr. Kornfeld.
Thank you, Kelly. So I just have to do something on my screen again. That excuse me. Okay, I think we're okay. Now okay, now I'm advancing. So here's the agenda of our talk today. So buprenorphine is unique among any medication or any opiate, and there is something called the waiver. And so we'll talk about that. We'll talk about why we want to use buprenorphine for pain, inductions, formulations, inpatient, functional restoration, insurance coverage, etc. So let's go to the understanding waiver requirements. So basically, for the last 100 years, it's been illegal for physicians to prescribe opiates in a normal way to addicts. And there's a long story about that, including a Supreme Court decision in 1919 that was 5-4 that made it illegal for physicians to do this. In the 60s, in response to the opiate epidemics of that era, the heroin epidemics, methadone was brought in and made legal for physicians to use, but only in the restricted context of methadone clinics. Then, as buprenorphine moved along in the research and development of buprenorphine, it became evident to public health leaders that this should be prescribed in doctors' offices. This is much safer. And so there was a law called the Drug Abuse and Treatment Act of 2000, and that allowed for a waiver of the usual prohibition against physicians prescribing an opiate to an opiate addict. It's too bad it took 100 years, but that's what happened. So if a doctor wants to treat an addict and there's not reasonable or significant pain, you need this waiver. Sometimes the waiver is called an X number because the DEA issues a special DEA number, which is your same DEA number, but instead of the first letter, there's an X. And there's an 8-hour course to qualify for this. There's quite a modest amount of paperwork involved. And when you get the waiver, you're allowed to treat 30 patients at one time during the first year. So you need to keep like a log of the active patients on buprenorphine for addiction. And then, when one falls off, you could take another one. After a year, you can petition for raising your limit to 100, and these limits may be raised in the future. If you have pain and addiction, there's no absolute guideline, and it's a matter of clinical judgment. And my recommendation is to practice good medicine and use good judgment and justify why you're doing what you're doing. So let's say someone who's shooting heroin, really actively, has a chronic, at least sprained ankle, I'd probably want to have a waiver to treat that person, On the other hand, if you had a person with a chronic pain condition, but periodically they take their opiate in an addictive way, I don't think personally that person needs a waivered physician. This is essentially a large percentage of the chronic pain population will occasionally use their opiate in a way. Sometimes it's called an aberrant behavior, or or maybe they're drinking alcohol, or maybe they're using cannabis in a dysfunctional way. All those things could be, quote, called addiction, but this is primarily a pain patient, and I'd like to advocate for doctors without a waiver being able to use particularly some of the FDA-approved forms of buprenorphine that are low dose and that are going to be available for chronic pain and are available, and we'll talk about that more a little later. So the basics of buprenorphine is that, like other opiates, it has an onset of action in about 30 minutes, maybe a little bit slower than some of the oxycodone or hydrocodone or hydromorphone preparations. And but it binds very tightly to the mu receptor. The mu receptor is the main opioid receptor that mediates pain, that mediates euphoria, and that mediates respiratory depression. But it binds very tightly, but it doesn't stimulate the receptor as fully as, let's say, a morphine type of opiate, so that there's some differences at the cellular level that are being discovered. And this partial agonist state leads to what's the excellent safety profile, in that respiratory arrest very rarely, if ever, occurs when buprenorphine alone is given to a normal adult. There are some very young children who can overdose on pure buprenorphine, and most adults who overdose in terms of a respiratory effect are abusing alcohol or are shooting up benzodiazepines or that kind of thing. So then there's the question of, there's a ceiling on the respiratory depression. Is there a ceiling on the analgesia? And it turns out that below 300 milligrams of morphine equivalents, this ceiling has not been detected. And then in terms of higher levels of morphine equivalent, there may be a temporary analgesic ceiling, but then if you stick with the buprenorphine, you get better and better analgesia over time. So the idea of an analgesic ceiling to buprenorphine really needs further research and elaboration, and it shouldn't be a limiting factor to prescribing buprenorphine. So you could have a very high dose patient and who has a lot of pain, and you could envision a rotation to buprenorphine. There's going to be some challenge to that rotation. We'll go over that. It's called induction. But we have ways to do that much better using the Butrans patch or the buprenorphine transdermal. But one shouldn't be scared, in my opinion, of rotating a high-dose full agonist opioid patient to buprenorphine. I've been doing it for 20 years, and it can be a little challenging. But once you get there, you're in such better shape to have a patient on buprenorphine rather than having them on high-dose opiates. So one of the main reasons is that they get better analgesia because there's something called opioid-induced hyperalgesia that the regular opiates are associated with the other opiates, and that can actually be addressed very effectively over time with buprenorphine. And then, as this slide shows, there's a lack of an immunosuppressant effect, which occurs with other opiates, relatively few drug-drug interactions, and it's quite safe in renal insufficiency. The dose doesn't need to be changed, and actually, it's quite safe also in hepatic insufficiency because most of the buprenorphine is excreted in the bile and excreted in the stool unchanged. Some of it is enzymatically altered with the CYP enzymes, but you really don't need that to get rid of buprenorphine. So it's the safest opiate in both hepatic and renal insufficiency. So this next slide is sort of a rationale of why rotate. Well, we know from the CDC that the benefits and risks start to move towards the risk when morphine is given in greater than 50 morphine milligram equivalents, and greater than 90, the risks rise even higher. So for this high dose patient, definitely to reduce the overdose risk, buprenorphine would be indicated. Also because of better analgesia, and also patients on buprenorphine over time develop more of a reverse tolerance and a tolerance. So over time, the dose can often be decreased if the patient is being managed well and managing themselves well, of course, for their health conditions. They could often taper buprenorphine to much lower doses or go off buprenorphine altogether, which is very hard to do for most patients who have chronic pain who are on full agonist opiates. Now, the low dose patient, although they don't exceed CDC guidelines, the patients we see who are on, let's say, hydrocodone, 5 to 10 milligram, BID to QID, we rarely see patients that look good that are on those dosages, which may still go under this 50 morphine equivalent bar, but these patients are on a roller coaster of the opiate effect. They often have disrupted sleep. Depression and anxiety is common, and yet they're very attached to this because it's the only thing that really gives any comfort to them because they're on the roller coaster. So, and also that these patients often are on this drug for many years. So here's additional rationale. Hypogonadism is very common in opiate treatment. There is some hypogonadism in buprenorphine treatment, but there's less so, and this has been established in evidence-based studies. There's much less sleep apnea with buprenorphine. Again, there's some documented sleep apnea. The whole issue of weight gain or loss, it seems that patients on full agonist opiates are prone to either gain weight or at times lose weight more than would be physiologic, and we see this much less with buprenorphine. We see much more of a normal lifestyle rather than a deconditioned and a sedentary lifestyle. I find less disturbed circadian rhythm. It's a very common story of patients on full agonist opiates that they seem to want to sleep half the day and then they're up half the night or the whole night. And I find with buprenorphine, if you give the larger dose in the morning and maybe a smaller dose in the afternoon, and sometimes they don't need any dose at all in the evening, they could get a very even circadian rhythm. The next line here has to do with constipation and sometimes what's called opioid bowel disease. So anyone on any opioid is going to have some constipation, with very few exceptions. Some people just don't get that. and all opiates, including buprenorphine, can lead to this. So careful management of laxatives and of diet is really important. There is a condition that's becoming more prevalent called small intestine bacterial overgrowth, and a lot of gastroenterologists don't test for this yet. It has to do with a breath test. There's an expert at Cedars-Sinai in LA, Dr. Pimental, and sometimes when people just have ongoing constipation or diarrhea, but with opiates it's usually constipation, this can be corrected by an approach for small intestine bacterial overgrowth with an antibiotic called rifaximin, which is a non-absorbed antibiotic, or with other means. Opioid-induced hyperalgesia, this is one of the things that really buprenorphine, again, is so useful for, and again, there's no gold standard test to run. Does this person have or not have opioid-induced hyperalgesia? But as you see someone who's gone up and up on their dose, obviously the tolerance is increasing, but it seems that some people develop, more pain the higher the dose goes. The last thing, we talked a little about the immune system. The last thing is the dysregulation of the HPA axis. This happens with powerful opiates, and of course this axis can be disrupted by the stress of chronic pain also. So in my opinion, buprenorphine treatment along with lifestyle, exercise, mindfulness can really restore that HPA axis, and of course restoring that HPA axis is important for sleep, for circadian rhythm, because the whole HPA axis is geared to that, where cortisol goes down at night, etc. So how to convince patients to switch? That's a big issue. So in our clinic at Highland Hospital, most patients who are referred to us who are on opiates, we switch to buprenorphine, and we pretty much explain why we say that this is what we're all about, number one, and where the future is going with opiates, and assure them that they'll have ultimately better symptom management, less sedation, the sort of withdrawal that they go through, the sort of roller coaster can be addressed, and what we have found also is that with buprenorphine, we seem to be able to taper them off of their antidepressants and their neuroleptic drugs. Now, of course, if these are essential for symptom control, we wouldn't taper them off, but we see so many patients who are extremely depressed, and they've been on antidepressants for years, and they've been on their full agonist opiates, and we find that when we switch them to buprenorphine, we could just gradually lower the antidepressant, and they don't get depressed. In fact, the more we lower it, they seem to get less depressed. And similar, that some of the severe anxiety that was associated with this roller coaster effect, they've been given neuroleptic drugs, they've been given the new generation, the quetiapine Seroquel drug, the risperidone, risperidol drug, and they've needed it, but now we find on the buprenorphine we could back those off, and often we get better weight control, and they wake up to the world. Obviously, the regulatory environment is better for buprenorphine. You could call this in without writing a wet signature script. It's a Schedule III drug, and functional restoration is also much more possible. We can get patients to do mindfulness work, to do exercise, to engage in physical therapy, to get psychotherapy. We've had good luck in doing that. So this is a slide developed by Dr. Jonathan Deitch, who's an interventional pain physician in Florida, has a very busy practice, but he discovered that that this was a great intervention in addition to his normal interventions to switch people to buprenorphine, and he switched many people and found that he got much better pain scores when he did that. So let's talk a little bit about buprenorphine induction. And Kelly, how are we doing on time?
Wonderfully. Things are going very well.
Okay, good. So the trick with buprenorphine is, why is buprenorphine induction important? So buprenorphine induction is important is because when a patient is on a regular opiate, and this could be morphine, this could be OxyContin, oxycodone, hydrocodone, this could be a fentanyl patch, this could be methadone, this could even be tramadol. Although tramadol is an unusual opioid-like drug that we're not going to talk about too much today, but whatever they're on, that opiate, it doesn't stick to the mu receptor anywhere near as much as buprenorphine does. So buprenorphine's strength in its stability on the receptor also makes it possible when you give it for what's called precipitated withdrawal to occur. So you all know what happens if you give Narcan, like to someone with an overdose. They wake up, you save their lives, but then they're actually quite miserable and they could be violent. So if someone is on a full agonist opiate and you just give them sublingual buprenorphine, maybe 20-30% will be okay, and maybe another 20 or 30% will be kind of unhappy but can grin and bear it. But a significant percent, let's call it 30-40%, will actually be quite miserable and unpredictable. It could precipitate a psychosis. It could precipitate wanting to use again, etc. So, often a trip to the emergency room. So you want to avoid this. And the way conventionally it's been avoided is there's been a protocol to stop the regular opiate and let some mild withdrawal start. And in order to do that, you could use something called the COWS score, COWS, Clinical Opiate Withdrawal Scale. But you could also, those physicians also who've been around know what opiate withdrawal looks like. There's some sweating, there's some piloerection, that sort of goosebumps, that's why it's called cold turkey, because you look like a turkey. And also the phrase kick the habit, that's because people get restless and they want to move their leg and have kicking motions. They get a runny nose, they'll get diarrhea, they'll get feelings of hot and cold autonomic dysregulation, and then they'll get pupillary dilatation. And one very reliable sign of that they're in sufficient opiate withdrawal is pupillary dilatation. But some people have a lot of other symptoms and anxiety before the pupils dilate. So it's always been a challenge to figure out when is a patient ready to get sublingual buprenorphine, because the sublingual buprenorphine goes in quickly. So these protocols are laid out really nicely by at least 3 different U.S. government-funded projects. One's called the PCSS, and one's called the NIDA Treatment Improvement Protocol, which is actually a book. And finally, there's bupractice.com. I believe the PCSS also has a call-in feature, or definitely an email feature. And the one criticism I have for these is that the PCSS and the TIP 40 emphasize that patients should be taken off of, who are already on buprenorphine, should be taken off buprenorphine for surgery. We have disagreed with that over the years and shown that it's better to keep them on. We'll go over that in a slide that's a little bit down the line. So when I was using buprenorphine a lot, and I would go to the PubMed, a lot of the literature on buprenorphine for pain was coming out of Europe. And the reason it was coming out of Europe is that in 1999, a company called Grunenthal introduced what we call a higher dose transdermal patch of buprenorphine, and they just started to convert people on morphine and other patients like that to the buprenorphine, and they didn't mention anything about precipitated withdrawal. And I kept looking in the articles. I say, why aren't they mentioning this? Because, you know, everyone in the U.S. is really worried about this with sublingual buprenorphine. And then it dawned upon me that the reason they're not mentioning it is that with buprenorphine transdermal, there is no precipitated withdrawal. So what you could have a patient on opiate, on full agonist opiate, and you apply the patch, and the buprenorphine goes in slowly so that it doesn't displace the opiate suddenly. It displaces the opiate gradually. And when that full agonist is being switched to the partial agonist, you don't get the withdrawal that you get with sublingual. So we found that we could rotate or use the buprenorphine transdermal bridge to bridge to sublingual buprenorphine. So in the U.S., the transdermal buprenorphine was introduced about 5-6 years ago, but it's a very low dose patch, but it's still high enough for the bridge to work. It's not the patches are 5 to 20 microgram per hour, where the European ones are like 35 to 70, but hopefully one of these days we'll get those. But even with the low dose patch, it works fine. Methadone is the biggest problem. If a patient is on methadone, and this is known to everyone who uses buprenorphine, that it's a real challenge because the methadone has a very long-acting quality, and it's hard to get a patient on high-dose methadone to go into withdrawal without being totally miserable, and they can't bear it for the number of days that's needed. So what we do is for patients on methadone, we start to convert them to a regular long-acting opiate, like long-acting morphine, like long-acting oxycodone, and there's some new kind of fancy long-actings like hydromorphone and hydrocodone, but we'll probably not even work with those too much. There's one called oxymorphone or Opana too. So we first convert usually to morphine or oxycodone long-acting, and we might do it in a couple steps with the really high-dose methadone. It's very tricky to kind of figure out what dose do you need equivalent between methadone and regular opiates. So whenever you convert in one direction or another, you always kind of go slow compared to the tables, and that's how you deal with methadone. So then you've got a patient on a long-acting opiate like oxycodone or morphine, and then with this slide, it tells you what to do. So we prescribe a box of buprenorphine patches, or some pharmacies, like our hospital pharmacy, will issue just one 20 microgram per hour patch, or you get 2 10s or 4 5s. This is depending on the cost and how this is going to be reimbursed. Then we get some sublingual buprenorphine also available. This says number 60. We may give a much smaller amount. You know, this would be a very stable patient that, you know, we don't want to send them back to the pharmacy repeatedly, but someone that we're just getting to know, we might give 12, you know, we might give 16, we might give 20, you know, because we want to bring them back fairly regularly, so we don't want to give them too many. So in this, first what we do is we convert the long-acting opiate to a short-acting opiate, and we give them a few days of the short-acting opiate. Then we stop the short-acting opiate the day before, and then we put we put the patch on the same day that we switch from the long-acting to the short-acting. So that's when the patch goes on. And so the buprenorphine is going in, but there's still a short-acting opiate covering the pain and the opiate dependency. And then we skip the short-acting altogether for an overnight or a day, and then we give sublingual buprenorphine. And I mean, it's just amazing how smoothly this goes. I recently converted someone who was on 25 high-dose Norcos. You know, he'd been in a couple of treatment programs. Every program was kind of a nightmare, you know. And we did it at home with just very careful management, and it just went. There was no withdrawal at all. And I have to say that he's doing quite well and managing on quite a low dose of buprenorphine and not needing anything for anxiety or sleep. And once this method gets better delineated, I'm hoping that it can be applied to the addiction world as well as the pain world. I should have said this. Legally, because of this 100-year-old, you know, prohibition law that we have, we can only use this bridge for patients who have pain. Someone who has pure addiction, they still have to go through the kind of suffering of the withdrawal before you give sublingual buprenorphine. So this slide tells a little bit more about the method that we just talked about. And this slide just also gives a little more. So if you go back through these slides, it'll explain this process a little better. So it turns out that Dr. Waller, Corey Waller, before we were working with the Butrans and collaborating, he had developed independently a fentanyl patch induction because, as it turns out, fentanyl binds pretty tightly to the mu-opioid receptor 2. It's sort of midway between morphine and buprenorphine. So what happens is that if you put a fentanyl patch on and then you stop the short-acting opiates for 24 hours, then you give the sublingual buprenorphine, you can decrease the incidence of precipitated withdrawal considerably. And in some communities and under some health plans, it might be easier to get the fentanyl patch right now than the buprenorphine transdermal, although I think that's going to change, and eventually the buprenorphine transdermal will probably be easier to get. One reason is that it's a Schedule 3 and you'll be able to call it in. So home induction versus clinic induction. Some clinics are exclusively doing home induction. In San Francisco, for example, most of us pick and choose the stable patients to do home induction. It is mentioned in the PCSS MAT. It could be really largely facilitated by the transdermal buprenorphine bridge that we just talked about. But I don't want someone doing it at home if they're alone. You know, I would like a reliable person to be with them. And I think in the future, there could be a kind of a home nursing or a home support system built in that will facilitate this better. And we like to bring the patient back in a short interval. And we try to avoid giving a full month for the first few refills of buprenorphine, but sometimes they stabilize so quickly that one feels secure in giving a whole month of the sublingual buprenorphine after a few visits. So sublingual buprenorphine originally came in an 8 milligram and a 2 milligram. The original brand names were Suboxone and Subutex. Technically, Suboxone applies to the film strip now. That was brought out as a safety factor because it's hard for kids to get into those foil packets. But pretty much generic buprenorphine or buprenorphine/naloxone are the generic forms that are most cost effective. The naloxone being with the buprenorphine is there to discourage illicit or parenteral use of the tablet, like crushing a tablet and injecting it. As it is, very few addicts would bother to inject buprenorphine, because if they wanted to do that, they would get heroin. But in the addiction setting, it's considered sort of a public health measure of safety to mainly use buprenorphine / naloxone. In the pain setting, I think you have much more choice, and the mono product with just buprenorphine is less expensive, and I think eventually insurance will favor this also. But 2 milligrams is actually 2,000 micrograms, and that's a pretty big dose of buprenorphine, because 0.3 milligrams, like if you want to compare the dose of buprenorphine parenteral to the dose of morphine parenteral, 0.3 milligram, which is 300 microgram, is equivalent to 10 micrograms of morphine. So milligrams of morphine. So 2 milligram is like almost 70 milligrams of morphine. So a 2 milligram buprenorphine tablet is technically a high dose. Sometimes we cut them in half or even a quarter. Rarely we have the patient swallow the pill if that's the lowest dose we could get and if they're too sensitive. If they swallow it, only about 10% gets absorbed through the stomach, rather than about 50% absorbed transmucosally. Many compounding pharmacists will make buprenorphine at lower dosages. And now there's, in addition to the buprenorphine transdermal, there's a new form called buccal mucoadhesive buprenorphine. The brand name is Belbuca, and it's a new product. It came out about 2 months ago. It's going to be heavily marketed. I'm hoping that those of us in the sort of the public health sphere will stay ahead of the curve, and it won't be marketed irresponsibly. But being buprenorphine, it's going to be a lot safer. So even if it is prescribed in a non-ideal way, it won't have the overdose risk or the addiction risk of the full agonist opiate. But if you're in private practice or you're thumbing through journals, be prepared for many advertisements for this buccal mucoadhesive. It'll be coming down the line soon.
Dr. Kornfield, we had a question about the use of buprenorphine for acute pain. For example, in either a primary care setting or an emergency department, if you have someone with a history of opioid addiction, but they're not on opioids now, what are the pros and cons of using buprenorphine for their acute pain?
That's a great question. When buprenorphine was first, it was invented in the 60s. It was tested and researched in the 70s. It was released in England in 78 as a pill and a parenteral, and it was released in the U.S. only as a parenteral. So in the early days of buprenorphine, they tested it successfully in all kinds of acute pain situations. You know, they tested it for fractures, they tested it for post-op, and it was the only opiate needed in many of these clinical settings, and people did well because it lasts a long time. You know, one dose of parenteral buprenorphine might last 8 to 12 hours as opposed to 2 to 3 hours that morphine or hydromorphone would last. So I think it has a role. There is some literature about using it in ICUs on sick patients, that it might be actually safer and that ICU patients might do better on it. At Highland Emergency Room, Dr. Andrew Herring is using it preferentially for acute pain when when an opiate is absolutely needed. I think it can become more and more a hospital-based drug as time goes on, and more people start using it and report on cases. I would prefer to start an addict who just had, let's say a hip replacement or a knee replacement, rather than get them on a roller coaster of oxycodone, for 10 days after their surgery. Maybe give them, for a few days of PCA an oral, morphine, and then get them right on the buprenorphine so that they leave the hospital on buprenorphine rather than morphine or oxycodone. So,
Thank you. Very helpful.
yeah. Now this slide just goes through the buccal film, and this slide is based on the official prescribing information that if patients on a low dose of oral morphine equivalent 30, you start at 75 microgram. It's a little film that sticks to the inside of the cheek. You give it twice a day or Q12 hours, and it goes up from 75 all the way to 900. But the protocol goes up to 300 if somebody's on 160 or less, and then they say if someone's on greater than 160, consider an alternative analgesic. I personally wouldn't consider an alternative. I would just either use the buccal or I would use sublingual buprenorphine. But the reason it says consider alternative analgesic is they are under the impression about this ceiling that really doesn't exist. So there's still a belief system that there's a ceiling when we've found that it really doesn't exist in the way that is commonly thought. This is a slide that goes into more details about all the different forms of buprenorphine. And as you see, the transdermal goes up in small increments from 5 microgram per hour to 20 microgram per hour. Now, let's say you have an elderly, fragile patient with significant pain. Whether they're on an opiate or not, it could be a humane intervention to use a buprenorphine transdermal. Of course, if their pain is controlled without an opiate, more power to that situation. If a little gabapentin handles it, if a tiny dose of Lyrica handles it, fine. If a Flector patch, or if a lidocaine patch, or if just functional restoration, fine. But if one of our elderly frail patients is in misery with pain, this would be a good place for a 5 microgram per hour buprenorphine transdermal. And if they're really fragile, I sometimes cut the 5 in half even, just so that I don't over-medicate them, over the first few days. Of course, the instructions say don't cut the patches, etc., but actually they cut really nicely, and they might not stick quite as good if you cut them, but you could use the cutting at least as a dose-finding maneuver, because once you order this, they like to give they like to give 4 of them for a full month, and it sometimes gets expensive. So the second line, we've gone over the low-dose buccal, and both the transdermal and the buccal are FDA approved for chronic pain. Then there's the same.
I would recommend we advance to the next slide, and this could be a good reference for people, just because we're short on time. And we want to do
great. So this was a series that we published, a colleague of mine and I published, where we took care of like 7 major elective surgeries in 5 patients, and we did not take them off of buprenorphine. Instead, we had them go through their surgery. They were on buprenorphine already. They went through their surgery. We arranged for them to be very carefully monitored post-op, either in a step-down ICU or on the floor with a monitor, with the O2 sat. And we just, proactively treated their pain with IV PCA kind of medication. And they did absolutely fine, with their pain. And one of the patients had breast reconstruction, which was very extensive, because I think it was a bilateral subcutaneous mastectomy with prosthesis insertion, and she was a little challenging, but she responded really nicely to hydromorphone in higher dosages. There are kind of scare stories out there. A lot of the surgeons don't understand this, and they write case histories that things didn't go well. and of course there will be the occasional patient you might want to you might want to switch to a full agonist if the buprenorphine, if they're on buprenorphine. But most of the patients should stay on the buprenorphine. It's much better for them. It's safer. They leave the hospital on buprenorphine. You don't have to go through a whole induction procedure to get them back on buprenorphine. So our functional restoration clinic, we've talked about these three elements of functional restoration, which are all of you are familiar with. Insurance coverage, no special TAR is required for addiction. Pain does require a TAR, although somehow our pharmacies in Oakland are finding that they will even just issue buprenorphine now for pain. But there is sometimes the pharmacies make a mistake and they send it to managed care instead of state fee-for-service Medi-Cal. So I think state fee-for-service Medi-Cal is called a TAR, and managed care is sometimes called a prior authorization. This might differ in different locales, but that's how it is in Oakland. Common challenges and opportunities. A lot of times, sometimes with buprenorphine, there'll be a honeymoon period. All the pain will go away for like a week. Then it'll start to sneak back. You do have to reassure patients that over the long run, the buprenorphine will work better and better. We sometimes have to use other medications like gabapentin. We even use a medicine called memantine right now, which is Namenda. It's an NMDA receptor antagonist that is approved for cognitive problems, but actually works in neuropathic pain. We might need to use a tricyclic antidepressant. We might need to use, in addition to the gabapentin, a sodium channel blocker like Depakote or oxcarbazepine. And rarely we add a full agonist to the buprenorphine. The problem with adding the full agonist is that often the patients get a little attached to the full agonist. One of the things is that they get euphoric recall of the full agonist. A lot of times they're in less pain, but they never get that really kind of euphoric high that they were used to getting, and they really miss that. And they interpret not having that as their pain being worse. But as you look at them, they don't look like they're in pain. They look a lot better on the buprenorphine. It's a steady analgesia rather than that roller coaster, which sometimes they get used to as maybe helping their mood disorder, but then they're miserable when the roller coaster goes down.
Dr. Gonzalez, a question came in about guidance for the dose that you need when you're transitioning opioid-dependent patients onto buprenorphine. How do you know how high to go on the buprenorphine dose? Do you use their previous opioid dose, or do you have another system?
Yeah, well, you don't generally need to use the previous dose. What you do is you start low. 1 or 2 milligrams would be your first dose. On the first day, you might go to 1 or 2 milligrams TID, QID. Then as the second, third day comes in, you can go up to 8 milligram, you go up to 12 milligram. Because once you get to these higher doses of buprenorphine, the dose response curve levels off. You're starting to get sort of more of the temporary full action of buprenorphine at 12, 16. But everybody's different, and sometimes we go up to 24 milligram within, the first week. Sometimes we go up to 32 milligram, which was in the literature, and I've even gone up higher, But everybody's a little different, and you try to stay low. But if a person's having like symptoms of pain or withdrawal, and then you give them a little more buprenorphine and they get better, then we let the dose go up, usually to about 24 milligram, which is the value in the prescribing information in the PDR.
Dr. Kornfeld, thank you so much. This has been incredibly valuable. And for those who may have started late. We asked Dr. Kornfeld to help us with a frequently asked questions document on buprenorphine, both for addiction and pain. There's details about the different types of induction that were discussed today, and it's a really valuable document. We'll be sending that out to you next week along with the slides and the recording, and you can also access that document on the website. I sent the link in the chat, but if you look at CHIF's website or Google Opioid Safety Coalition resources, you'll see it there. I did want to leave space for Dr. Cindy Grand, a rural doctor in Washington who has been using buprenorphine for pain as a primary care doc in a rural setting for quite some time. And I asked her to tell us a story about her experience as a way to bring this home and reassure all of us in primary care that we have the skills to do this. Cindy, are you on the line? I believe she's been unmuted.
Hello, can you hear me?
Yes, we can hear you.
All right. Well, wonderful presentation, Howard. Thank you very much. I learned a few really useful things. I just wanted to tell you a story about a 55-year-old female patient of mine who I actually inherited already on buprenorphine about 3 years ago, and she was doing really well. And when looking back at what happened before, she told me a story, and I typed out every word that she told me, and because it was so just really, really clear. And I just wanted to read you what she said. She said, the longer, this is regarding the Vicodin that she had been on before, the longer you take them, the more they make you hurt. It creates pain. You get tolerant to it. And then you think, I'll take just a little more. And then you take a little more. And pretty soon you hurt worse than you did before you started taking them. I would wake up and the pain was so horrible, and the pain was never like that until I started taking pain pills. The brain creates this fake pain, a magnified pain that really isn't there. Your body is screaming for it. I experienced a cyclic depression. In between doses, you would get a depressed feeling because you knew you weren't supposed to take another dose, but you hurt, and this becomes cyclic. When you take buprenorphine, you get your whole mental stability back. You don't have to worry about feeling dopey or driving. It gives you your life back on a plate. So she actually gave me that story, and I wrote it down. And then when there was a problem with when she switched to a different insurance company, they no longer paid for her buprenorphine. And so I appealed it, and they denied the appeal. And I sent this letter to a director of the medical director, and believe it or not, it was still denied. And I finally actually was able to appeal it up to a national level, the national medical director of that insurance company, and that person finally agreed to pay for it for her. But sometimes we run into some serious insurance problems in Washington that make it really hard, even for somebody who has obviously had a huge advantage from buprenorphine. So that's kind of the battle that I'm fighting all the time, but it's just so rewarding. This story that she gave me was just, I have a lot of patients that have that kind of a response, but she just really articulated it clearly.
Well, thank you. And if you Google Lucinda Grand with an E on Grand, you can see this story. I think, Cindy, you've published some of your stories online, and they're very, very moving. And I specifically asked Cindy to join us because as a rural physician, as a family doc, it sometimes can be intimidating to start these new practices, but we're finding family docs across the U.S. who are starting to see that the old way that we treated pain is causing harm and is not helping people feel better, and seeing this incredible before and after stories. This is not a holy grail or miracle drug, nothing is, but some of the doctors who've been using this for both pain and addiction tell me it's the closest thing they've seen, where the people they used to hate seeing in practice, where there'd be agonizing arguments over dose escalations and running out early and chaotic lives, become people they love seeing in practice because they get to see the person in that mix of that chaos emerge, and a person who's now stable is able to focus on things other than the next dose, the next pill, and the next refill. So again, Dr. Kornfeld, Dr. Grand, thank you so much for joining us today. CHCF does have a series of webinars every month focused on a variety of topics on the opioid epidemic. By joining this webinar, you'll get on our mailing list, and we'll send you emails about upcoming events, so do stay tuned. And thank you again. We hope you have a wonderful afternoon. As I mentioned, we will send you next week the slides, the recording, and the buprenorphine frequently asked questions document.